Thank you very much, Miriam, and thank you very much, Anna, for having set the scene. I agree with everything that Anna has said, apart from perhaps the order in which the medication should be tried. Deep brain stimulation has been around for a very long time, and the very surprising thing is that it's very useful against the worst symptoms of many genetic dystonias that have different phenotypes, that is, a different clinical expression. And the question is, why should one intervention be so useful for so many different disorders with completely different mechanisms of action in terms of the molecular biochemistry that underpins their disorders? So we know, if we look at childhood dystonias, that the majority of childhood dystonias begin under the age of 2. That means they're going to spend the whole of their lives with dystonia. And the question is, when do you intervene with a lifelong condition that interferes with the very early beginnings of a child's motor career? Do you wait until the wheels have come off the bus, when the transmission is broken, when contractures and deformity have occurred, or do you try and intervene before that has happened? And then, putting aside the mechanical problems, do you wait until all the life chances and opportunities which a child may have for learning, for socialization, and friendship has been lost, or do you try and intervene at a time when they can still be more active and participate? So this is a philosophical question, but it's also a human condition question. If we look at the balance between genetic dystonias and non-genetic dystonias, in red is what we would be calling the cerebral palsy cases. In green are the cases we suspect as having a gene disorder but cannot find the gene. And in blue are the known genetic disorders. Now, I have to say blue is expanding, green is getting smaller, and red is getting smaller. And the question is, how many more GNAO1 cases are there buried in these early onset dystonias that people have classified as cerebral palsy with bad epilepsy or with an epilepsy beginning and so forth? And until we have a universal means of screening children who have early onset developmental delay, movement disorders and epilepsy, we are going to be in the dark, and we won't have a good idea of what proportion of our children have these disorders. This is based on almost 600 children that have come through our service, representing all the referrals, most of the referrals for deep brain stimulation in the United Kingdom. And of course, when we look at the genetic disorders, it's this multicolored pie diagram. And here we have GNAO1, which currently is a very low 4% of the known genetic disorders that we have. It turns out that it's about 0.6% of the 600 cases that I've discussed, but that's because most of the cases we haven't even done genetic analyses, because when they presented, such analyses couldn't be done. There was no laboratory or test that we could use. So I'm going to try and present to you 5 consecutive cases, all the GNAO1 cases that have had deep brain stimulation in the United Kingdom in chronological order of presentation, to try and give you a flavor of what has happened to all 5 of them. None of them got infected. None of them have had hardware problems. Only one of them has had a switch-off problem, which is easily corrected by switching on again. So we can't blame the equipment or the software if we're unhappy with the result. So the first child is a 12-year-old girl who had had a history of developmental delay and an onset of severe intermittent deterioration from about the age of 6 following tuberculosis treatment. And then she was admitted to the intensive care unit and quite typically had all the infusions with Aslam. She was under anesthesia. She'd had haloperidol, tetrabenazine, which I suggested that they stop because the problem with these children is that we keep on adding medicines and not taking any away. We put her on a clonidine infusion up to very high doses. which can only be done in an intensive care unit. We stopped the trihexyphenidyl because her gut had stopped. That's an anticholinergic drug. And then she was airlifted from Manchester to London for deep brain stimulation. I'm sorry. This is the one I really want, actually. This file has been causing me a lot of problems because it's so big. And here she is after her deep brain stimulation. Now, I didn't show the film of her under anesthesia because it's just a child who's not moving under gaseous anesthesia with a ventilation tube. And you can see she's quite happy, even though she has got a bit of a dyskinesia there. And here she is, about a week after her deep brain stimulation, and she's beginning to engage with the therapist. You can see the dyskinesia is still there, and also the floppiness, but she's also on a lot of medication which causes this. Here I want you to see that despite the fact that she has a movement disorder, she has intentional movements, she has voluntary function, but it's being countermanded by her movement disorder. And I think one of the issues that we have to think about is that these children often don't get an opportunity to express or demonstrate functions because people think, oh, you can't do it, or it looks so terrible. So these are the deep brain stimulation settings. These are for the people who do the DBS. She went home on much less medication. And I visited her in Manchester. Sorry. And this video shows an important illustration about the oromotor dyskinesia, where the tongue moves around in the mouth so much that it whips up the saliva and makes a foam. And I call this cappuccino mouth because it's very difficult to do, but it's a very good sign of oromotor dyskinesia. You can see that she's still nasogastrically fed here. And these are her early signs of attempting to stand and walk. And she's markedly better, but there are still a lot of difficulties. Yeah, I don't do this, go through this. So this is a special time test, which is a universal test of mobility for all ages, all conditions. It's a test of being able to stand up, walk to a wall, and then walk back again and sit down. It's very low tech. It only requires a stopwatch. You don't even need a video, but we do video it because it's always important to look at the function. And she's able to brush her teeth, even though it's quite an ordeal to watch her do it. The important thing is that you've got to let the children have the opportunity of doing it. I'm worried that I may not have time to let you see it in its entirety, because she does achieve it. She puts the toothpaste on, she brushes her teeth, she puts it all back on the sink again. Okay. And then, in 2017, we actually got a diagnosis that this was GNAO1. So people say, don't do an intervention if you don't know what the postcode is. On the other hand, for the majority of our children, we don't know what the diagnosis is. If the clinical conditions are right, you should intervene and then find out the genetic diagnosis later. I think waiting for getting these rare genetic diagnoses is actually counterproductive. And here she is 7 years after her deep brain stimulation. I think in the UK we might call her a goth because she likes a lot of black. She has a very, very wry sense of humor. She likes writing stories where terrible things happen to people. I got her to write the line, "The quick brown fox jumps over the lazy dog," and then she said, "and the fox chewed the dog up into little pieces. Okay, there she is. She's writing the sentence. This is what it looks like. It's just about legible. And we use a satisfaction and performance scale here, and a 2-point change is indicative of positive change, and these are 4 and 5 points, this is 6 and 6 points, this is 8 and 7 points, this is 5 years after the stimulation. This is the dystonia scale, which has gone down by about 40%, and the disability scale down by 40%. These are the settings. Now, we change the rate of setting here, of the speed of stimulation, because she's very slow. Everything she does, it's almost as if in slow motion, and we're hoping that with the lower frequency of stimulation we can speed up her motor system. But at the moment we're waiting to see that. This is a caregiver priority of child health index of life with disabilities, and you can see that when she began, her overall quality of life was said to be 0, and it moved up to 80%. And a lot of these things have improved enormously. So when you're going forward with a terrible movement disorder, do remember to measure things that are not to do about the movements, but more to do about the life of the child with the movement disorder. So that's my largest file. I'm going to exclude it now because I don't want it to spoil the rest of the presentation. So the second child did have a diagnosis of GNAO1 because it was picked up by the Deciphering Developmental Disorders program, the DDD program. This is a girl who was presented at 13 years with a severe status dystonicus, and she had the typical early history of slow motor development, although she achieved walking and talking and so forth. And she was sent to us for consideration of DBS, even though actually she was quite functional. And when we first saw her, we thought, well, she's really good. She's got what we called a pallidopyramidal syndrome. In other words, she had both a movement disorder and problems with spasticity in the legs. And we said no. And within weeks of coming to see us in London, she developed status dystonicus. So we said yes. And she came in and she was on the usual medication that you would think about. In fact, we had to recommend that she had continuous clonidine infusion, and when she arrived, she was on continuous nasogastric clonidine infusion. So I'll just move forward to the video. So less hurry, more speed. Okay, so I think you're now familiar with the severe dyskinesia of GNAO1. But in some cases, you can recover and play football. The walking and running pattern is more to do with this pyramidal disorder, which is the disorder of the direct motor control of the muscles, which is quite separate from the movement disorder. She's going to get all of these balls in. She's had 1 or 2 episodes of mild dyskinesia, and perhaps some seizures. There have been very, very mild seizures, and we haven't really been convinced that it's a major part of her current life. But I think what people are really interested in is what happens afterwards. Now, she's just turned 18 years old. This was actually in the summer. She went to her prom, and she really has, rejoined the human race. Let's just go through all that. Okay. So I'm picking these off so that they don't interrupt things. Now, The family of this young boy are sitting in the audience now, so I hope I'm not going to say anything that's going to be upsetting. But again, the typical story of early onset motor difficulties with flurries of sudden movement disorders that can't be explained. But it's really by about the age of 8 that he has a really severe bout of status dystonicus and is admitted to the intensive care in Birmingham. Now, all of our children have had status dystonicus, and they've all been in intensive care, all 5 of them. One question is, must every child go through intensive care before they get DBS? Do they have to have the experience of intensive care? Does the family have to have the experience of the child going into status dystonicus or dystonic choreathototicus, or should we actually prevent them from going into intensive care? This is what happened to the CP child. You'll see that, again, scores of 0 improving and so forth. And then also the goals improving for the family. So in other words, the satisfaction of the families looking after their child after they've had DBS is often very high and speaks volumes. Now, a lot of people looking at a child like this would think, well, they're in a world of their own, they're not able to connect with the world, whereas what he's trying to do is look at that DVD on the computer that his mother is holding. And momentarily, he sees what's on the screen, and then his body takes him away. And then, of course, in the middle of all this, suddenly he'll become almost akinetic. So he has periods of akinesia and dyskinesia. Now, this is terrible, because you're not in a state of control in either state. It's probably safer to be in an akinetic state, but he can still make choices with his eyes, and we saw a very beautiful example of the eye gaze technology and how that revolutionizes the life of children who have no control over their movements. So he had deep brain stimulation, and he was able to achieve a very important human function, which is to sit and to be able to look around him. Most of the time when children are in bed, they look at the ceiling. If you look at the ceiling, this is a very, very disabling process. To be in society, you need to look horizontally where the world is. And this is where achieving seating is actually a very important achievement. Here he's attempting a writing skill. He can't perform it well, but at least he has an opportunity of trying to do these things. He had some orthopedic surgery, which went slightly complicated. The system got infected. He was hospitalized for many, many, many months. Thank goodness he's got over that, and he's back into this condition now. So, I think we're down to the last 2 cases. So this is a boy who also had a known diagnosis because of the DDD study that gave us a gene. He had a very aggressive course, and also he had problems with a floppy airway, which we call laryngotracheomalacia, and I'll show you that in a minute. We were able to prove that he had normal motor pathways, and normal sensory pathways, these are anatomical neurological pathways, and I think it's very important that we can demonstrate that essentially the motor system is intact. It's just the motor control system that is not intact. Okay, and I'll just skip through the history. which is mainly that of motor milestones not being achieved, and move forward to the inevitable menu of drugs. And here he is in the pre-DBS assessment period. You'll see that when he tries to breathe in, his chest moves in rather than out, and this is because of the floppy airway. We were talking yesterday about, is the tracheomalacia part of the GNAO1, or is it part of something else, or is it exacerbated by the multiple drugs which the children are on? But this will show it more clearly that when he breathes in, his chest moves in. It should actually move out to take the air in, but it actually does the opposite because there's an obstruction in the airway. And this later on caused problems because he was admitted twice after the DBS in respiratory failure, not in status dystonicus. So that's why he subsequently got a tracheostomy. So you can see he's had deep brain stimulation. He looks extraordinarily young when you take his hair away and give him a bandage. But you can see he's smiling. He's still a bit jiggly. It's taken a long time to peel away the medication. A lot of families find the medication is a sort of security blanket. They're absolutely terrified that if you change them by 1%, something terrifying is going to happen. But gradually confidence has grown, and he's been able to come off a lot of medication. He's also grown in size and weight, but actually he's very content. Again, a lot of the work with the children with these disorders is concentrating what the eyes are doing, because the eyes are the only method of communication. So it's very important to be focusing on that. You can't do it lying down, you have to do it in a seat, because then you can use eye gaze technologies. And it's very encouraging that 1 year after his DBS, his DBS was May last year, our physiotherapist Sinead is going to let go of the head, and you'll see him doing some self-supported sitting, dangerously on the edge of the bed there, but she's there. So this is a tiny hint of self-efficacy coming up. Okay. And now for the final case, which is going to tell a very important story about when do you intervene. And again, we knew the diagnosis for this girl, so you can see how as soon as you get the postcode, you can make much more rapid decisions. And she had developmental delay, little flurries of worsening movements, but in January of this year, she went into status dystonicus, and she's been in hospital ever since, on a lot of medication, and she came down to London to get her deep brain stimulation. This is a sleep chart, which I talked to some people last night. The family said that she would spend days not sleeping, and you cannot function as a human being without sleep. You cannot develop, you cannot survive. And this is a chart to show you how in the evening she's beginning to develop some sleep, and she's beginning to sleep all night. In fact, there are some charts now that shows that she has very good night's sleep. So a management strategy for all children with dystonia-dyskinesia, no matter what the cause is to make sure that they are sleeping at night. And my second goal is to make sure they can sit in a chair so that they can be active and participate in ordinary human life. This is her DBS system. Because she was only 2.5, we were concerned about the equipment, but she did weigh 12 kilos, and my minimum weight is 10 kilos. So she had her DBS implanted, and this was her pre-DBS. It's pretty awful. And this is going to illustrate a very important function, which is that on the bed, being supine is a pro-dystonic posture. In other words, it worsens dystonia. If you can flex the hips, this is an anti-dystonic maneuver, but the question is, how do you maintain this? She's on a lot of medication, and children with GNAO1 are naturally floppy, and you give them medicines that make you floppy, then it's, you know, a worse situation. So coming off medication is really important. So probably the youngest person in the world to get DBS, but also the youngest GNAO1 case to get DBS. And so the question, I think, to everybody else is, you know, you've seen the stories, you've seen the crises. Should DBS be offered electively rather than always in an emergency? Thank you.